know, I was there dancing too.
Here we are. Awesome. Good. So I haven't run our banner for a while. Maybe I'll run it for a little bit. See.
Yeah, everybody is welcome.
Yes, everybody's welcome.
Yeah.
Ketogenic diet is not just.
We have a big tent.
Yes,
We have to, or else I'll have to leave.
Shut up.
Yeah, although we don't endorse M&Ms, but sometimes they happen.
No, but you know what was funny? Sunday, I had 2 patients, and their names were both, or their initials were both MM.
Oh, okay.
And then my coworker started talking about M&Ms, and I was like, "What is happening?"
You're in this strange alternate world.
I was getting signals from somewhere. Okay, I'm just saying.
So how are you feeling?
So I've not been totally carnivore.
Well, that's okay. I mean, what have you been
doing? What?
That's okay. So what have you been doing?
Not very good. I started off strong, right?
Uh-huh.
But yeah, it's not gone well.
It all starts with a first step,
Well, and I know no pressure or anything, but and I know you're one of our beta tester members on Healing Humanity Life. We are going to be starting a Tuesday, Thursday evening Breaking Addictions group. We've been having our morning Monday, Wednesday, Friday group, and a lot of people are having breakthroughs in their addiction. And I've actually rewritten the material. So it's based on the 12-step program. And the original material that we went through in December was based on a book. I'll show it to you. This book here called Back to Basics, but it's written for Alcoholics Anonymous. And it's where you go through all the 12 steps in four sessions, 4 1-hour sessions. And we don't call them sponsors. We have accountability partners. But I over the past couple months have been rewriting basically the program for carnivore or keto. So it's not even like Overeaters Anonymous, because Overeaters Anonymous, it's always focusing on overeating standard American diet, and people can't break through, right? Because it's not about overeating. It's about the food that you are eating. And so we have, the book is done, few little edits, and it's going to be published, but I have PDFs that are in the group. But it might be something that might help you to possibly consider, going through the program, because like I said, a lot of people have been experiencing some really good breakthroughs with because it is an addiction.
So one of my problems is that I am so all or nothing.
Yeah.
Like I'm either 100% on board or I am not. And I did well in the beginning last time because I was 100% on board.
Yeah.
And it's not just a matter of being addicted to other foods. It's like kind of a will thing too, like the beginning of the week, I really want to do this. And then I'm like, I don't know if I want to do that. Like, part of me wants to do keto. And then part of me is just like, I don't know what I want to do.
Excuse me, you guys. I guess it's allergies. I don't know.
That inner person that seems to be fighting against another inner person,
Well, one problem I have is that I still can't reconcile when I was on carnivore how my sugars always stayed above 100.
Mm-hmm.
Like that doesn't. I would need somebody to explain that to me. And also my hemoglobin A1C went up, right? Yeah. I didn't go get the test to confirm that was actually real, but I do know that my morning pretty much my baseline glucose was above 100 fasting and otherwise,
That's the same
and it never got down to 80 until I stopped carnivore. And then when I started adding other things in, then I would go down to 80 and 90. I'm like, what is going on?
Yeah.
So,
Yeah. Interesting.
I don't know. It doesn't make sense to me. I've tried, and that's one reason I'm reading this book, because I need for it to make sense. I need to know, not just because I've been dogmatic about carnivore and wanted to do carnivore. Like, I've been like gung ho about it. I love the community, all that stuff, but I need for it to make sense, like with my body, like that it actually is the right thing for me to do.
Yeah. Yeah. Well, we're in the endocrine chapter, and once we get through this liver, we've got metabolic syndrome, we've got diabetes coming up, and blood sugar, and you've got, we've got this chart here. I'm seeing a glucose response. So I'm fully anticipating that we're going to delve into the things that you're
I hope so.
About. Yeah. Absolutely.
I hope so. Oh, but I will tell you one good thing that I have done this week, okay, is I have been addicted to Crystal Light since I got off of sodas, right? And it was just like my replacement, and I felt like I needed that sweet taste. And so even though I haven't stuck with carnivore this week, I have been drinking plain water instead of Crystal Light. So
celebrate the victories.
It's been a small victory, but it seems like I don't drink as much either, because I was just constantly grabbing that thing. And that, that could also explain my elevated sugars. Maybe, I don't know, The
only way to know is if you do another CGM.
Yeah.
See what happens,
Well, but I mean, I don't guess it really would, because when I was still drinking Crystal Light when I got off of carnivore too. So I don't think it's a Crystal Light, but like, I definitely don't think it's good to drink Crystal Light every day, all day.
What kind of sweetener is in Crystal Light? Is it sucralose?
I don't remember.
It might be. I think that's one of the ones that is less good, I guess, could cause problems. So, okay, good. Well, we're here to support you, and, we got your back, and, you're on your journey, and hopefully we can get answers as we go through this. I'm curious too about why your sugars were still elevated.
Well, and mine are still like that. I mean, now I haven't been testing my morning glucose. I haven't tested it in quite a while, but I mean, it was like right around between the 90 and 100, maybe sometimes even a little over 100 mark. Now, the last time I went for labs, though, like actually to the doctor, I had gone to a concert the night before. That's actually happened twice when I've had labs done. And since I had been up so late and got up so early, my fasting blood sugar was actually at 110. And also my A1C had gone up to, I think it was 5.5, but I got that fructosamine test, and it showed me like dead center, like in the range.
Oh, okay.
And so I had asked Dr. Berry about that in his private group and gave him my labs and stuff during one of his in-group lives. And he said that, perfect.
Absolutely. And we got Dr. Nelson in here. Let me get caught up in the comments. Coach Lisa, I'm gonna have to tell you guys, I've been starting her program, so I'll have to give you guys a little bit of a update on that. Josephine, hello.
Hey.
That's Carrie. Dr. Nelson. Love it. Say good. Okay, we are on page. Yeah, good. We're on page 113. So
in our
Ketogenic Textbook. Okay, so if anyone's new, we are working through this textbook here. It is a medical textbook called Ketogenic: The Science of Therapeutic Carbohydrate Restriction in Human Health. It is not a book club, so we do not read ahead. We read and discuss and review as we go. It is high level, at least this section.
It's way above our heads, aka.
We're trying to make heads or tails out of it.
Walls of text.
For he wrote this section, it's like, whoa. But Yeah.
I think they were showing off myself.
I think so too. I think so too. Doctor, we figured out that what he doesn't do well is to let us know when he's talking about normal function versus dysfunction. He doesn't transition well in between. And so he'll mention something about some pathways and then he talks about dysfunctional and there's no transition between the two. We're like, wait a minute, that doesn't make sense.
I feel like if you're a biochemist, you could just read right on through this.
Probably.
But if you're a normal person, you're going to have to read each sentence like 5 times.
Yes. Yeah. So anyway, so I'm getting started with Coach Lisa's program, Life Back System. And I'm trying to time it so that, because there's like week 7 and 8 on it is this cleanse. And so for me, I have to be super careful with cleansing. And so I'm trying to time it so that week 7 and 8 follows the Tennessee meetup so that I'll be not cleansing while I'm traveling, because I know you can feel worse when that's happening. So Monday through Friday, she does she does a workout, and she has a private Facebook group for people who enroll in her program. So I went on the Facebook and yesterday, and they even filmed me, which I may actually put on my channel, little clips from it, me trying to do the workout. Right. So I'm like, happy, all's good, yay. And then I'm going, but wait a minute, Lynn, this is just the warm up. Like, don't get too cocky and overconfident that you know. I'm like, cool, this is my pace, but it's still the warm up, right? But and it was a weight bearing Pilates. And the last time I did any Pilates was when Lindy and I did our arm flab challenge with this Pilates video, and it was so hard. So I did non-weight bearing because I figured I'm gonna just see what I can do, because she has you like get these little dumbbells and like put them in the crook of your knee as you're doing these things with your legs. And I'm thinking, let me just do it without the weights and see how far I get. But there were these kind of modified planks that were different I hadn't seen before. So I was able to do those without any problems. But yeah, the farther we got, the more I'm like, oh, hamstring cramp. I feel it coming. It was a lot of legs. Yeah. So I don't know. I might have been able to do maybe 40 minutes, maybe.
Hey, that's good.
That's pretty good.
A lot of that was the workout, the warm up, but I did finally just give up and go, okay, this is enough. Can't do anymore. When I'm starting to feel my muscles, the cramping setting in, I know that that's when it's time to stop, or I'm going to end up in pain, writhing on the floor but she really encourages drinking at least 80 ounces of water. And I am horrible with water. And with all the storms, I haven't really been able to get out and do grounding and get out, because it's like crazy storms that we've had here. Yeah. So it's going to be a work in process for me.
Yeah.
Well, aren't we all?
Yes, we are. And so far I'm doing okay with the lemon. I know I mentioned last week that there was a little concern about the lemon. I had a little acid reflux, but that's gone away. So I'm doing okay now with the lemon. So far, I think. But, all right, good. Well, let's see. Last week it was mostly Carrie reading. So we're on page 113, and the paragraph is like the third full paragraph.
Yeah, it's the one that starts out that says in obesogenic.
Yeah. Kim, you want to start?
Okay. In obesogenic individuals, the prevalence of NAFLD is nearly ubiquitous. Higher rates of hepatic fibrosis are observed in diabetic patients, 56.4%, compared with pre-diabetic, 29.2%, and normal glycemic patients, 28.6%.
Okay, wait a minute. Sorry to interrupt so quickly, but did those percentages shock you between the pre-diabetic and the normal glycemic?
Yeah, that's what I was just looking at.
I bet you it's because a lot of the people in this normal glycemic category are already insulin resistant. What do you guys think?
In the
Or
normal
they drink
glycemic?
more high fructose
Yeah,
corn.
like the pre-diabetic, the rate is 29.2. Normal glycemic is only 28.6. It's less than a percentage, insignificant amount of difference between those two.
Yeah, it could be.
So I'm wondering, is it because they're
I don't know.
yeah. Well, and it's so interesting too, because I know as I've been kind of scouring the Facebook group for Coach Lisa, there's a lot, she focuses a lot on the liver, and there's a question about liver damage without seeing anything as far as elevated liver enzymes. And this is interesting because it obviously, when it comes to least diabetic patients, you can have liver damage long before you're even diabetic.
Yeah.
Mm-hmm.
That's ridiculous. That's almost 30% of people that have normal blood sugars that already have damage to their liver.
But don't they say that fructose, like while it doesn't elevate your glucose level, it does cause fatty liver? I'm sure.
Yes.
Yeah.
Mhm.
Yeah.
So I think that could be a part of it too. So these people who are normal glycemic, they might not necessarily have a lot of sugar and stuff, but, or, enough to be diabetic yet, but they are
No, I thought
consuming
fructose
that.
does still elevate.
I mean, it's just too many factors to even really.
I think fructose
Yeah.
still does doesn't it still raise your blood sugar? It's just your liver doesn't know how to process it.
Well, I don't think it factors in on your A1C.
Okay.
Because that's the whole issue. Remember the whole thing about carnivores eating fruit?
Well, the thing is fruit has glucose and fructose.
Yeah.
Right. It does, but
if
there's
we're talking
damage
like
being done that
strictly,
you're not aware of because it's not showing up when you do lab work.
Yeah, they say that fructose is actually like 7 times more glycating than glucose, but
Yeah.
I don't know if that's true. I don't even know where that came from.
Yeah.
I think I heard Dr. Berry say it.
Yep, I have.
Yeah, Dr. Nelson said that's why sugar is the root of all metabolic evil. Yes, and ChatGPT says that fructose has minimal direct effect on hemoglobin A1C compared to glucose.
Yeah,
because it's metabolized differently in the body. Yeah,
Mm-hmm.
but it does contribute to increased insulin resistance, liver fat accumulation,
Mm-hmm.
and some fructose is converted into glucose in the liver that can contribute a little bit. So.
Okay. All right. So patients with NAFLD and type 2 diabetes show accelerated progression to cirrhosis. NASH occurred in 59.4% of diabetics, 49.2% of pre-diabetics, and 36% of normal glycemic obese patients. Only 1.5% of diabetics had no histological hepatic alterations.
Wow.
Several NAFLD progression and fibrosis scoring systems have been developed to determine the rate of progression and timing of possible transplantation. Medical treatment for NAFLD or NASH requires reversal of insulin resistance. There are no medications that do this completely, but metformin and GLP-1 agonists, with or without GIP receptor antagonists, do have a desirable effect in reducing insulin resistance and thereby potentially the severity of NASH. Blocking triglyceride formation and anti-inflammatory medication has failed to resolve the disease. Research into inhibiting triglyceride synthesis improves hepatic steatosis, but exacerbates liver damage and fibrosis in obese mice with non-alcoholic steatohepatitis. Statin therapy and low-fat, high-carbohydrate diets also exacerbate disease. In foregut and bariatric surgery, it is common practice to place patients on a very low-calorie diet a month prior to surgery. But the sustainability and efficacy of this diet shows poor results. However, clinical experience using our NAFLD reduction protocol of 5 to 7 days of near total, less than 20 grams of total carbohydrate restriction, while eating protein and fat unrestricted, results in biopsy-proven resolution of NAFLD in osmotically overloaded swollen livers. NASH is more resistant to treatment, but can certainly be stabilized by total carbohydrate restriction. Adding the biguanide metformin, a glucagon suppressor, as a way to dampen glucagon-mediated paradoxical glycogenolysis and gluconeogenesis may speed up the resolution of NASH. Clinical experience indicates that if intermittent fasting of 48 to 72 hours with aggressive transient treatment of blood glucose using continuous glucose monitors with long and short-acting insulin to maintain normoglycemia in combination with total carbohydrate restriction is the most effective way to treat NASH in biochemical and radiologic improvement.
You know what's interesting? I'm sorry, I'm interrupting again, but you know, like thinking about this and thinking back to all the years that I was working in GI, given that this is all has already been tested out, like I never heard any of the doctors, the GI doctors, tell our fatty liver disease patients to restrict their carbohydrates. Never. Not even once. And honestly,
the only ones that'll do it is the obesity doctors before they do the bariatric surgeries. That's like pretty standard practice now.
And you'd think that the GI doctors would know this, and because they would, you know, the advice that they would give would be lose weight slowly. You don't want to lose weight too fast because that can actually damage the liver when you're dealing with fatty liver and elevate your liver enzymes initially, but never. Yeah. Like I was there for 8 years. Never did they say, go on a carbohydrate restricted diet. Never.
Yeah. That's a shame.
It is.
Let's see here. Further evidence implicating monosaccharides, but not PUFA in NAFLD and NASH comes from total parenteral nutrition, or TPN, data. In long-term TPN patients, which is just as a reminder, that is where we feed people through an IV. Okay. In long-term TPN patients, there is near universal hepatic fibrosis and cirrhosis, often requiring liver transplantation. Standard clinical TPN macronutrients include 15 to 25% dextrose solution that usually requires the addition of insulin for blood glucose regulation, amino acids, and a 20% high PUFA, low saturated fat lipid emulsion. Standard clinical monitoring manages hyperglycemia with insulin, not dextrose concentration reduction, as well as serial peripheral triglyceride testing with reduction in lipid emulsion infusion for high triglyceride concentration. Many studies have altered timing, cycling, altered fatty acids, and protein mixes that only resulted in minor alterations to the inevitable hepatic cirrhosis outcome. However, because of the common erroneous belief that carbohydrates are an essential source of energy, there are no studies eliminating dextrose from TPN. In my practice, I have not used dextrose in short or long-term TPN in any patient over the age of 2 years for over a decade, including type 1 diabetics. We have not seen any evidence of NAFLD by blood testing, imaging, or biopsy, and have also not seen hypoglycemia. This is true despite the mandatory use of high omega-6 PUFA in the lipid component. And even when triglyceride concentrations are high, there is no evidence of NAFLD. In addition, we have rarely required insulin infusion except in type 1 diabetics while maintaining normal glycemia. Clinical experience shows the risk of catheter infections and venous thrombosis is also significantly lower. However, these data have never been accepted for the publication because no international research body has given permission for such a study, and the use has always been off-label. The data provide additional proof that carbohydrates, not PUFA, cause NAFLD and NASH. Wow.
I know.
As someone who regularly
I'm
used
just
to,
like, this is.
I used to regularly give people TPN and lipids, and you knew that they were going to have higher incidence of infection because you're just giving them sugar into their, that's just
bacteria love sugar.
Yeah, it's just heartbreaking, really.
Dr. Nelson says the main source of CME we receive is heavily influenced by big pharma.
Unfortunately.
Yeah. Hey, Sonia.
Fibrosis may progress to cirrhosis and complications, including hepatocellular carcinoma. Once cirrhosis has occurred, this cannot be resolved, but can be stabilized by total carbohydrate restriction and aggressive medical treatment of hyperglycemia until the patient is insulin sensitive, then potentially deprescribing the medication is warranted. Unfortunately, when end-stage NASH is treated with liver transplantation, the recurrence of NASH is common since accelerated injury occurs if the diet remains high carbohydrate, particularly with the use of steroids for immunosuppression. So not only are we hitting them with high sugar, but we're knocking out their immune system. It's a combination for, infection.
Yeah. And liver transplantation, I mean, they look at these comorbidities and deciding who gets a liver transplant, but they're not even factoring in. I mean, if it's non-alcoholic liver disease, there's I don't think they even factor in what caused it. I mean, they just get a new liver if they don't check other boxes with comorbidities.
Yeah.
Yet the environment in their body that caused the problem is still there, which is a shame because somebody had to. Well, now they're able to do more live transplants. At least it's not always, but sometimes in clinical trials. But yeah, it's like someone died to give up that liver.
Yeah, it's just really sad. All right, you want me to keep reading?
Sure.
Okay. Managing the patient, clinical presentation, investigation, and treatment. The liver is a highly regenerative and resilient organ, such that pathology usually presents with glycemia, lipid, and hormonal disruption, rather than intrinsic liver injury apart from the aforementioned NAFLD-NASH spectrum. NAFLD-NASH injury is assessed by elevated lactate dehydrogenase, aspartame aminotransferase, so LDH and AST, and alanine aminotransferase, or ALT, gamma glutamate. Sorry, I've got a child in the kitchen. Hold on, let me move my microphone. Gamma glutamate transferase, GGT concentrations, radiologic imaging, and liver biopsy if necessary. Fibrosis scores can be used to calculate severity of injury. The liver is primarily responsible for nutrient, substrate, and energy distribution to all cells in the body. Based upon energy utilization capacity, and in particular insulin production capacity, dysfunction may be seen as a myriad of conditions. Hyperglycemia due to early failure of the liver. Hold on one second. Okay, I'm just making sure that it's on. Can you all hear that rattling?
Not too bad.
No? Okay. I was making sure my microphone was directed this way. Okay. Number 1, hyperglycemia due to early failure of the liver to convert glucose into fat in people with low insulin production, resulting in early insulin-resistant, diabesogenic, intravascular thromboinflammatory vascular disruption, atherogenesis, and vascular occlusion. Number 2, intracellular glycemic energy deficiency, or number 3, persistent hyperinsulinemia causing massive lipogenesis and obesogenicity with pathological adipocyte hypertrophy, steroid hormone synthetic disruption, and cholesterol/protein hypersynthesis. and intracellular inflammation.
Okay, am I the only one that needs to read that again?
Oh, dear God.
No.
So basically, number one, hyperglycemia due to early failure of the liver. Okay, wait. The liver is primarily responsible for nutrient, substrate, and energy distribution to all cells in the body. So basically, your liver is giving your body its nutrients and energy.
And I have to interject that we have Mike Shaw here.
He is here. We've missed you, Mike.
Hello.
You get a liver.
You get a liver.
Okay. Based upon energy utilization capacity and in particular insulin production capacity, dysfunction may be seen as a myriad of conditions. Okay. One, hyperglycemia due to early failure of the liver to convert glucose into fat in people with low insulin production, resulting in early insulin resistance, diobesogenic, intravascular, thromboinflammatory, vascular disruption, atherogenesis, and vascular occlusion. So some clots and some inflammation in your vessels.
So by people with low insulin production, that's somebody who's already, their pancreas is already dysfunctional. They're either, no insulin production, that would be the type 1 diabetic, right?
Mm-hmm. So their sugar's high due to early failure of the liver to convert glucose into fat in people with low insulin production. So
insufficient insulin. So pancreas not working properly.
Yeah. Okay. Or 2, intracellular glycemic energy deficiency. Okay. So they don't have enough. They have a deficiency of sugar causing energy inside the cells.
Yeah, the cells aren't getting.
Sugar you can use as energy inside the cells, basically. So what would cause that?
Good question.
Insulin resistance, maybe?
Yeah. Because your fat cell, your cells won't let it in if you're insulin resistant.
It's kind of like in the brain when there's it's like, what do they say? Like all the water and not a drop to drink.
Yes.
Because it's not able to pull the sugar in.
Not able to pull it in.
Mm-hmm. Yeah. Water everywhere.
Yeah.
Drop to drink.
Yeah.
Mike Shaw, what's that from?
Okay. And then number 3, persistent hyperinsulinemia causing massive lipogenesis and obesogenicity with pathological adipocyte hypertrophy, steroid hormone synthetic disruption, and cholesterol/protein hypersynthesis and intracellular inflammation. So basically, your insulin is very high, and that's causing massive fat
formation,
making a fat cell formation, and just making you really obese,
making your fat cells big,
making it hypertrophy. So grow. And then this is interesting right here, steroid hormone synthetic disruption. So steroid hormone disruption. So that makes me think of like cortisol, maybe they're getting the big hump on their neck. I don't know.
I'm sorry. That just struck me as funny.
Yeah.
Well, that little hump? Yeah, I got one. It's high cortisol. Yeah, it's high cortisol.
Really?
Yes. Haven't you seen it on people? It looks it can also be caused from forward head posture, but mine's not that. Mine is hormonal. But no doctor will tell me that. I'll be like, "What's this?" And they'll send me for an X-ray.
Well, did they tell you?
I know what it is.
Do they say it's kyphosis or?
No, they're like, and I know what it is. It's high cortisol.
Yeah,
it's the same hump that it's a similar hump that people who have
Like Addison's.
yeah, or not Addison. Isn't it the opposite of Addison's?
Oh, yeah.
Yeah. What is it? High cortisol. Oh, they have the moon face and the round bodies with the stick legs.
Yes, I know. I'm just drawing a blank right now. Let me see.
I can't believe I forgot.
It's coming. It's coming.
Chat,
Cushing's.
come on.
Cushing's.
Cushing's. But and I've always known it was the same principle. Like it makes sense. Like you're insulin resistant, all of your hormones go together. One of them acts up. It's only a matter of time before the other ones act up.
Yeah.
Okay. So my cortisol's acting up. And as you get closer to menopause, your cortisol will spike higher also.
Mike. Or you guys just, let's see. Mike says, I need to read more. You got me on that one, Carrie. Or you guys just read to me. Read Iron Maiden.
Okay.
The missed Mike.
Yeah. He's the levity.
Yes. You can only I can bring levity to this material.
Yeah. So early morning fasting blood work, including lipid panels, NMR if necessary, hemoglobin A1C, blood glucose, C-peptide, insulin, glucagon, ketones, uric acid, vitamin D, testosterone, and inflammatory markers are needed to evaluate hepatopathology, as well as determine genetic pattern. Craft oral glucose.
Liver enzymes.
What?
Notice it didn't say liver enzymes.
I don't know.
Yeah, I mean, you think it would include a comprehensive metabolic panel or a liver panel. It didn't mention that at all.
Craft oral glucose tolerance testing is also often of value to elucidate genetic pattern and disease severity. Monitoring for autoimmune diseases is also important. A coronary artery calcium score, CAC, may assist in vascular disease risk assessment. Follow-up blood work every 4 to 6 months shows trends and return to fat-adapted insulin sensitivity that may take 6 to 12 months to manifest after implementing total carbohydrate restriction. C, your insulin resistance may take 6 to 12 months to, it should say resolve. It says manifest.
Well,
it's saying insulin sensitivity may
take
okay, that makes sense. It's just, it kind of said it opposite of how I wanted it to say, but whatever.
Yeah, the wording
is insulin resistance should resolve insulin sensitivity
because the insulin sensitivity is getting better. Treatment requires addressing the root cause. There is no pill that treats a self-induced lifestyle problem. Effective treatment is with total carbohydrate restriction, particularly low fructose, including intermittent fasting with no more than 2 calorie-consuming meals in a 24-hour period to restore glucagon insulin hormonal cycling. Metformin and GLP-1 agonists, GIP receptor antagonists, medications that improve insulin resistance and hyperglycemia may accelerate the restoration of this relationship, but aggressive return to normoglycemia and insulin sensitivity is the most consistent way to reverse NAFLD and possibly early NASH, even if that requires transient use of diabetic medications. There are no other medications that have been shown to reverse NAFLD. Abstinence from alcohol is also strongly suggested during the corrective phase. Frequent physical activity to induce glycogenolysis is also strongly recommended. Use of ursodeoxycholic acid, 3 omega fatty acids, vitamin E, and thiazolinidiones,
Big word.
geez Louise, have failed to show convincing therapeutic benefit. Medications transiently slow down the progression of the consequences of such lifestyle conditions, but addressing the cause requires behavioral change that cannot be outsourced, mitigated, or medicated. In other words, just do the work.
Just do the work.
Only catastrophic endpoint damage, such as stroke or myocardial infarction, is irreversible. Metabolic syndrome, insulin-resistant diabetes, NAFLD, and obesity are eminently reversible, often to remission over time with near abstinence from carbohydrates and snacking. But remission only remains as long as total carbohydrate restriction is followed. Therapy begins with physician-led education, including dietary and psychological therapy. That's what I need.
I was going to say, maybe that's the component you've been missing.
Yes. And follow that's not funny. Like, I probably really do. And follow the monitoring of health, diet, as well as psychological state. Dietary relapses are expected and common at first.
There you go, Kim.
But after you've done carnivore for over a year, you should know better, girl.
Not expected any longer.
Let's see here. But quitting carbohydrates repeatedly after each relapse usually leads to sustained abstinence and improved quality of life. Psychological and dietary counseling and support groups assist patients in understanding, transforming, and maintaining their diet. Patient-centered metabolic monitoring of weight, blood pressure, blood glucose by glucometer or CGM, and ketone monitoring are all of value as feedback metrics.
Do you ever monitor your ketones?
I mean, on blood strips, yeah.
Yeah.
Yeah,
Okay.
and that's another thing is when I was on carnivore, my ketones were like 0.2, 0.3. Like they were fairly, and that was in the morning. I always checked them in the morning. So I don't know. Anyway, okay. Disease-specific medications should definitely be used to control the results of metabolic derangement. This includes tight blood glucose and blood pressure control by whatever means necessary. Metformin and GLP-1 agonist, GIP receptor antagonist medication, even in hyperinsulinemic patients, has value in gluconeogenic suppression and hepatic glycolysis. Low-dose aspirin, a thromboxane A2 inhibitor that blocks platelet activation, may be of value in hypercoagulable states. This medication, if tolerated, should be continued well into the fat-adapted state. Appetite suppression medications may be transiently valuable in helping a patient gain dietary control and may even include bariatric devices and surgery if warranted by disease and comorbid severity, since caloric restriction of any kind, as well as consumption frequency reduction, has transient benefit. Salt supplementation, including iodized salt up to 150 to 200 mics, is essential. What? That's not a lot.
That's not a lot.
I recommend more.
I recommend Dr. Berry's version, salt
Yeah.
to taste.
Yeah. Vitamin and micronutrient supplementation, essential fatty acid supplementation, fish oil, particularly DHA, up to 1,000 milligrams a day, is prescribed as needed. MCT or coconut oil has early value in accelerating return to a ketogenic state and may have hepatoprotective value since these shorter chain lipids are absorbed via the portal vein directly to the liver. Statin therapy is not warranted for patients on total carbohydrate restriction diets and may negatively affect hepatic cholesterol handling. Real and processed food with a preference toward animal micro and macronutrients, particularly of marine sourcing, most closely resembles the best nutrient supply for the entire gastrointestinal tract, with the liver at the metabolic apex of the entire intestinal system. Physical activity, adequate high quality sleep for circadian rhythm restoration, and daily exposure to sunlight is of great physical and psychological value. Every physician treating metabolic disease with total carbohydrate restriction and intermittent fasting should have a medication prescription protocol. And then it says see figure 3.5.
3.5.
So in summary, ultimately diseases caused by chronic excessive carbohydrate consumption, carbophilia, and lipophilia are best treated at source by removal of carbohydrates and snacking with addition of complex, naturally occurring fat. This does not seem difficult to understand, but cognitive dissonance right here and societal transformation is a very slow process. The best we can do is guide individual patients down their own path of recovery and remission by educating and leading by example.
Awesome. That was a better section. It was a lot easier to understand.
Yeah.
So get caught up on some comments here. Mike just started on back on the Keto Mojo, gamify all the things. It really helps. Yes. Gamification. Dr. Nelson says, whatever gets your blood sugar better.
I saw that as something else. Your BS. Yes, it is.
I interpret it as blood sugar, but it could work both ways. Mike says that all sounds like work and dedication, but it's better than the sad disaster waiting to happen. Yes. So this section was actually like easier to understand because he wasn't going into biochemistry.
Yeah. Like once we slowed down and looked at it again, then it clicked better for me anyway.
Yeah. And there were so many things in here that like my functional medicine doctor is always trying to do with me. And I'm thinking, well, maybe I should take her up on the metformin just like temporarily until I get my insulin resistance better. I don't know. And so she's always recommending metformin, and it's actually shown to extend life. Like a lot of doctors in the ketogenic space even will take it, even if they're not insulin resistant, they'll take it just because of the research behind it. And then also I had heard good things recently about, and I think it was on Dr. Boz's channel and maybe one other channel. I can't remember which one, but basically about taking ketones, even if like you're not on a ketogenic diet even, or, that they still have some brain benefits and then also getting out in the sun and what else? There was, and then the fish oil thing, I think that we need to not take pills because most of those are rancid. If you look at the data on that, most of the ones tested are not good. They're actually, I don't want to say they're more detrimental but that's what I read. So you might want to look into that and eat fit.
Tea oil?
Yeah.
Yeah. Does it help at all?
I don't know.
I use it in my coffee sometimes.
Yeah, I used to do it in my coffee all the time.
I don't drink coffee every day, but when I do, I usually put butter and MCT oil in there, and it's almost like just a sort of a keto energy drink,
I never really noticed anything, but
I didn't either.
Yeah, it would just like give me more energy.
I feel like it's a good thing though, and like I believe that there's research behind it.
Well, I like that part where I like it, but where it says that the MCT or coconut oil has early value in accelerating return to a ketogenic state and may have hepatoprotective value since the shorter chain lipids are absorbed via the portal vein directly to the liver. So it sounds like that's a good thing to have happen. So
yeah,
I'm all for it. and then of course, like, and Kim, you do the same. You eat sardines too, so you probably don't even need
Yeah.
fish oil.
Yeah.
I eat cod livers about every other week. It never has gotten really any better for me. I've had people say to try to mix it with tuna fish, and I may try that.
Mhm.
I don't
I've
know,
never
but it
tried
seems
it.
to me that I could just like drink it or drink it. I was reading that message that I can just, like sort of scarf it down real quick. There's less, but if I mix it in with other stuff, then there's more volume that I would have to eat and I would still taste it. So it's like I
Yeah.
just go ahead and and I have not tried to make the pate like Dr. Berry and Nurse Nisha talk about.
I don't think I'm interested in it, to be honest with you.
But I do try to eat the
Sardines.
liver because it's better to get it from the source rather than
Yeah.
trying to take supplements. So that's why I eat it.
It's a sardine pate.
No, I love sardines, so I eat the heck out of them. I
But
can
a
eat
liver?
sardines, but cod
talking about-
livers,
Cod
Yeah.
liver. Well, we've got a
they're slimy.
we'll eat liverwurst. I mean, we have to look at the ingredients because a lot of it has sugar. But I found one in our local grocery store that has really clean ingredients and no sugar.
Yeah.
Yeah.
So
I've
what
never
Mike
worked
was
before,
saying before we
but
go
I
on to the
could be
next
in the
comment.
mood for it.
Oh, what Mike
Yeah.
was saying about
Before
one?
we go on to the next comment, what Mike just said, so I can't do heavy cream. That is one thing that I have discovered, even since I got off carnivore, is I should not have been doing dairy because dairy does feed my candida. And once I got off of dairy, that kind of, seemingly resolved even off of carnivore. So
Yeah.
I do coconut milk or coconut cream in my coffee, and it's delicious.
Okay, well that's good.
Mm.
So okay,
And it's very low carb as well. It's no added sugar.
Yeah.
cool. So I actually ran this one. I've run this one through Chat GPT because I don't have I haven't ever researched on it. And I know I'm wondering too, like with any sort of replacement, if we're looking at possibly just like this is talking about, maybe temporarily bridging over with medications until you get to the point where things are balanced enough on their own. If that might be something that, what do you guys think about that when it comes to?
I 100%
You're like 100%
am
on therapy.
I am on hormone therapy. It has turned my
Big game changer for you.
It has been a everything changer for me. So I think progesterone cream is wonderful. I just take my progesterone orally, but I think that it's great.
Yeah. So
And then estrogen cream as well is really beneficial. And hormone replacement has been shown to be cardioprotective, and so protecting against strokes and heart attacks. And also it's been shown to decrease osteoporosis. And I mean, you can read up on it, but
yeah, it supports thyroid function, stabilizes blood sugar. So it says a carnivore diet, which eliminates plant-based estrogens and reduces insulin spikes, may naturally improve hormone regulation. But if your body is, let's see, so it says if your body is already adjusting to lower inflammation and better metabolic function, you may find that your need for external progesterone changes over time. So it's probably worth evaluating.
But there are also protective benefits of progesterone. I can't remember right now.
So it says the carnivore diet is high in fat, which could potentially enhance the absorption and utilization of progesterone.
Oops.
So it might be more effective if you're eating a carnivore diet.
And I don't even have a uterus, but I still take progesterone. Most of the time, people without a uterus don't take progesterone, but I still do because you have progesterone receptors all throughout your body, including in your brain. So, Dr. Berry had said before that his thinking on it was that you just because you don't have a uterus doesn't mean you don't need progesterone replacement.
Right.
So
Right.
Mhm.
This says if you're on a carnivore diet, you may need less. It could to be equally effective. You may not need as much. So, yeah. So,
progesterone can protect against a number of conditions, including cancer, osteoporosis, and heart disease. It can also help with mood, sleep. Oh my gosh, sleep 100%, and cognitive function.
With
the
I have
estrogen,
kind of
my
been toying
hot
with it.
flashes.
I just might do it. I'll have an appointment coming up.
I highly recommend
April.
it. My hot flashes are gone. Any of my anxiety, I was having all kinds of anxiety about stupid stuff. I would lay up at night and think, oh, what if we have a fire? Is the dryer still on? Oh, it's only got a few more minutes. Should I? And it was ridiculous. Like I was I've never been an anxious person, and I just had so much anxiety. I would just lay there and I would feel scared and like insecure. And I'm like, what is going on? And that's what it was. So,
yeah, awesome. Good.
I recommend, Carrie.
I'll check into that. I had my hormones tested last time when I went. I go every 6 months. Of course, I had my physical the last time. This next time is like the checkup, the 6-month checkup. And so I think I ended up getting on that schedule just because my cholesterol was high. So they were following up. But I mean, now that I have a 0 CAC score, maybe, they don't nag me about statins anymore, but I'm still on that every 6-month thing, which is fine. But I'll go and maybe see about the, hormone therapy, maybe just like even light. I don't even know how they work out dosage or anything. I will have to read up on it.
Have you had blood work done?
Yes, I did. I had it done the last time, and basically I'm in menopause.
Yeah.
Well, and also like they don't even treat, like a lot of them are really resistant to even testing. And the reason why is because they treat by symptoms.
Mm-hmm.
Because what can happen is if you're in perimenopause, you can have symptoms for 10 years. And meanwhile, your levels are just doing this right here. And if you test and you're up here, they'll be like, oh, nope, sorry, you're not in menopause, but you're still having perimenopause symptoms, and you can still start and feel better. And that's the main thing. Is my thing is if men had erectile dysfunction,
they go get
and it would be like there would be so much research. It would be, you know what I'm saying? Like there would be, if men needed hormone replacement, they would get it.
Mm-hmm.
So I think that women need to, like, research on this kind of stuff has not been done. Like over the years, women have not been researched like they should be.
I've heard though that men don't get that they're afraid to give men the testosterone because they say it's that mistaken thing of it causing prostate cancer.
Which
There's
is
been lots of questions on Dr. Berry's channel about that, where they won't give it to them.
If that was,
I'm no expert on that, but like it just sounds crazy to me, honestly.
It sounds crazy, but it's in that Lies My Doctor Told Me.
Yeah, it was covered in Dr. Berry's book. But if that was the case, all the young men would have prostate cancer.
Right.
That was my thinking, but I mean,
doctors still won't prescribe it. It's just
like
crazy.
I said, I mean, this is not medical advice. This is this is not medical advice. This is just advice from a girl on the internet, a woman on the internet who is now no longer suffering because she's taking hormones. So whatever it's worth.
I think I'm going to look into it.
And your skin too. Oh my gosh. Like your skin without hormone replacement is it's gonna really suffer.
I didn't want to go over, just because we're talking about the topic, the symptoms of low and high progesterone, because I think it's since they do make decisions off of symptoms. So low progesterone symptoms, irregular cycles if you still are menstruating, anxiety, sleep issues, low body temperature. If your progesterone is too high relative to estrogen, your symptoms may be fatigue, dizziness, and bloating.
I mean, those are so like all the symptoms are so generalized.
Yeah.
They
But
are.
if your estrogen is low,
Right.
that's really when they start replacing both, from what I understand.
Yeah.
What is going on?
Let's see. So the last 4 days I've been eating sardines, cod liver, shrimp, and oysters, all mixed together with a little green salsa. Oh my goodness.
Oh,
That's a lot.
okay.
Fish. Awesome.
Mhm.
Got off my derriere. Mike doesn't have a uterus either. You're twins.
Twins. It's like,
Oh my gosh.
Awesome. Steak Mom says, thank you for your input. I'm 49-year-old and have been carnivore for almost 7 months. Yay. And it definitely has not helped hot flashes. It has helped hot flashes, but not
Has
helped.
helped, yeah.
Yeah. In 7 months, it can take a while for sure.
Well, mine was almost instant. When I started eating low carb, those hot flashes, they dipped down tremendously.
Yeah.
But the anxiety and stuff was still there.
Yeah.
And I would still have some, but I am also 49, Steak Mom, so we're the same age.
Oh, Mike.
We've missed you, Mike, so much.
Yes. Thank goodness Mike's back.
Yes.
Oh my goodness.
It's like the old days.
Yeah,
Awesome.
I really haven't had severe, I'm probably in menopause, labs don't really show it, but I haven't had severe menopause symptoms. Like,
well, you may not be in menopause yet either. Like, do you know when your mother went through menopause? Because usually that's a pretty good indicator.
So she was 50. My sister was 55 when she went through menopause, and in April I'll be 57.
Yeah.
So,
I mean,
who knows?
it's hard to say.
But I had, my whole adult life, I had PCOS. And so
so you may not even notice.
Yeah. My hormones.
You may just think that's normal. You know what I really noticed aside from the anxiety was joint pain. I mean, just so bad that I would lay, and this was before carnivore. Now, carnivore really did improve it, and keto also. Keto and carnivore both like greatly improved it. But like I would be laying on my side at night and I would hurt so bad. Like just my bones would just hurt so bad. And I would get this upper arm pain that was really strange. But in the middle of the night when I wanted to turn over, it was like, oh, I mean, I had to work up to it. And it's just not normal. Like normally I just flop over,
too, before carnivore. Like seriously, I felt like my body had to work in segments to get myself hold over.
That's what it was. Mm-hmm. And that upper arm pain, they say that a lot of people get it, but it is so just weird. I mean, you're just laying in bed and like your upper arms just hurt. So anyway, I'm dramatic about everything. I'm sorry.
No.
I'm like, it's so bad. You're dying.
Oh my goodness.
Yes, we love you, Mike Shaw.
Glad to see you, Mike. It's been a while.
Yes.
So awesome.
It's great to see everybody, but
for sure.
This is awesome.
I know. I mean,
I'm so glad.
I always appreciate anyone who endures our reading through this because it's not light reading at all.
It's not exciting for most people aside from us three, right? But we're going to be doing metabolic syndrome next, and I'm so excited about that.
Me too.
And this is written by someone else. So I don't know this person. Hasina Kaji or KG or Kaji. Yeah, so it'll be interesting to see if this is a little bit easier reading.
And she's talking about like other hormones and insulin resistance.
Yeah.
Dyslipidemia with insulin resistance. Oh, also just being in menopause is going to increase your insulin resistance and your inflammation.
Yeah.
So.
Ooh. And we have some nice colored diagram. I'm going to have to start putting together a little PowerPoint presentation soon. We've had page after page after page of solid text,
white and black text.
Yes. So finally, we have this looks like it'd be a hard PowerPoint slide because it's a lot, but we've got an actual table on the next page. So we'll see.
About the electron transport chain.
Yeah,
All right.
That's exciting.
Awesome. Good. So next week we will tackle the section on metabolic syndrome. And yeah, it's a long one, but then we have type 2 diabetes
Yeah.
after that. And let's see. Yeah, lots of information on type 2 diabetes. So that's really cool.
Yeah.
So cool.
I'm wanting to read ahead now. I never do, but I'm just like, I want to read it. I don't want to wait.
Yeah. Oh yeah. Lots of really, looks like there's lots of really cool graphics coming up.
Mm-hmm.
We just have to get through. Oh, it covers PCOS and infertility.
Oh.
Coming up too. So.
Oh yeah, this is going to be awesome.
Yeah.
Yeah, Mike, you better show up for that one.
Yeah.
Yep.
We got to get your PCOS taken care of, Mike.
You and Kim are twins. Yep. So
He doesn't have a uterus, remember?
Well, but I have one ovary, so you can still have PCOS.
I actually still do.
Mike,
have
did
ovaries,
you keep
but
your
I don't have a
ovaries?
uterus either.
That's right.
Mike, did you keep your ovaries, or did you get rid of those too?
Oh my goodness. Also good. Well, this was fun. It was fun. And we will be back. Let's see, what do we have here?
Mike said he moved back to Texas.
Oh,
Yeah.
awesome. Are you coming to the Austin meetup on March 8th? We are having, he says he's fresh out of ovaries. We do have farm fresh eggs.
Well, that's as good as an ovary.
I have some farm fresh eggs too. I've got a source. I'm so happy.
Goodness.
Nice, beautiful colored farm fresh eggs. They're great. They look like Easter eggs.
Nice.
Oh, I love
I've
that.
got a source. Yes.
So Mike, if you're anywhere remotely around Austin and can come to the meetup, definitely say hi. And you can get tickets on the healinghumanity.movie site if you want to go. That'd be awesome. So it's going to be a kind of I don't know what, maybe 5 or 6 hours.
So is there more information on the Nashville?
Big Mom, I have ovaries. Awesome. Oh,
I have one, and it's like, help.
Yeah,
Is there more
Nashville.
information about Nashville?
Yeah, well, so the Nashville, we have a venue. It's April 13th.
13th. I've got it on my calendar, but I just need to.
We do have a venue. If you go to, and then we're selling tickets.
Okay.
Yeah. So you can go to the healinghumanity.movie and then go to the events tab. And all of
March 13th.
March 13th. And I'll be there.
Cool.
I have
Okay.
something on
I'm
March
going to get tickets for me and my brother.
Nice.
Yeah, so you get to meet my almost carnivore brother,
Awesome.
who is just as skinny as me.
Yeah.
On a Thursday?
April 13th.
Oh, you said March 13th, I thought.
Sorry. No, March 8th is Austin. April.
Oh, maybe that's what I heard.
Yeah, April 13th. We didn't
March 13th is a Sunday. Yeah, I have to
Yeah,
look
we
at
weren't
that day.
excited about having it on a Sunday, but we're doing more filming with Dr. Barry, and he had the 12th available for us to come to his ranch to film. So
I have to work that Monday and Tuesday, so
yeah, that makes it a little harder for people who have to travel from out of the area.
Yeah.
But how close do you live to the ARC exhibit in Kentucky?
I think about an hour, 45 minutes to an hour.
Because Dave and I and my daughter and son-in-law are all going to go. We're going to be there for a week, and we're planning on the days prior to the meetup is driving up to Kentucky to go to the ARC exhibit.
Oh.
So we'll be in your neck of the woods.
Well.
Have you been there before to the ARC exhibit?
No. No. I'm not a Ken Ham fan.
Not a Ken Ham. I'm just curious.
No.
I thought it would be really cool to go tour it and see what it's all about,
Yeah.
Yeah.
I mean, like my mom went, she tried to get me to go. I'm like, no, I'm not going.
Did she like it?
I guess.
Okay.
I don't know.
Well, I'll let you know. I'll let you know what I think about it and see.
Yeah.
But it's like, how often do you actually have an opportunity to go and see something like that? It just is kind of like, wow, huge project.
I mean, like, if it's your thing, then sure. It's not my thing. I mean,
Yeah, I don't know if it's my thing yet until I go, so we'll
Yeah.
see. But I'm looking forward to it, and yeah, so cool. Let's see. All right, yes.
Yeah, he said he's closer
Oh,
to
close to
Nashville
Nashville
now.
now. Oh, okay. All right. Let's see. I didn't know about March 8th, but maybe. Awesome. Cool, cool, cool. Yeah. All right. Very good. Well, thanks everybody for hanging in there with us for this highly intense material. And if you enjoyed it, we will be back again to cover more next week on metabolic syndrome. And have an absolutely fabulous week.
all right. Bye,
You all have
guys.
a great week.